Hi, my name is Jade, and I'm a freshman nursing student here at U of M. I was placed into Heartland Healthcare Center as my first clinical rotation. The patient that I had is a 90-year-old woman who worked throughout her life as a bartender. Medicaid has been her usual source of medical care. The patient finished high school and that is her highest education. The patient was also never married but has 2 children. The patient's temperature is 98.5 degrees Fahrenheit taken orally. She has a pulse of 86 beats per minute, a respiratory rate of 18 breaths per minute, and a blood pressure of 147/76. The patient has been placed into Heartland Healthcare Center because of a facial fracture due to a fall, and she also experiences numbness on her top lip, which started occurring after the fall and fracture. She is now prone to falls. The patient's fall was described as she tripped getting out of bed, where she hit the left side of her face, which occurred at the Heartland Healthcare Center. She arrived at U of M Hospital after the fall via ambulance. Once she arrived at the hospital, she denied symptoms of headache, nausea, vomiting, and loss of consciousness, as well as any other injuries. The patient's biggest risk factor for more falls was identified as her age. She also has multiple falls before her most recent fall. 5 years ago, she also shattered her left shoulder and still has problems with shoulder pain after a fall. She has been diagnosed with arthritis, COPD, dementia, depressive disorder, hyperlipidemia, hypertensive disorder, osteoporosis, and type 2 diabetes. She is up to date on her influenza, pneumococcal polysaccharide, and tetanus plus diphtheria plus pertussis vaccinations. Patient does not have any active allergies and has not had any surgical procedures. Patient is taking albuterol, amoxicillin, and clavulate, azolistine nasally, caforazim menthol topical, cholecalciferol, citalopram, cyanocobalamin, diltiazem, docusate, gabapentin, and insulin glargine long-lasting. Because of the patient's history of falls, I performed a musculoskeletal assessment as well as a neurological assessment with cranial nerves. Some normal findings during the musculoskeletal assessment were that the patient had no sign of scoliosis, a full range of motion in her temporomandibular joint, elbows, wrists, and knees, full muscle strength in the fingers, hips, and quadriceps as well. Some other or abnormal findings during the musculoskeletal assessment were that the patient had a hard time walking because she needed assistance. It appears that she has kyphosis. There was not a full range of motion in her neck, shoulders, hips, and ankles. She had pain in the temporomandibular joint, neck, shoulders, fingers, hips, and ankles during assessment. The pain in the temporomandibular joint she reported as being due to uncomfortable dentures. There was pain in the neck on the right side during pressure and motion, pain in the left fourth phalange and the right third phalange due to arthritis. And then she also had weak muscle strength in the deltoids, biceps, triceps, and ankles especially. Cranial nerve assessment. Due to inadequate resources, we did not assess cranial nerve 1, the acuity portion of cranial nerve 2, the light touch portion of cranial nerve 5, the Weber and Rinn portion of cranial nerve 7, and the gag reflex portion of cranial nerve 9, but that wasn't due to inadequate resources. It was just part of a courtesy thing. The only abnormal finding was that the patient could not pronounce dynamite in the portion of cranial nerve 12, but this could be due to problems with hearing and her old age. When performing the mini-mental exam portion of the neurological assessment, just due to the patient's immobility and arthritis, I did shorten the mini-mental exam only to include certain portions. The patient scored a 5 out of 5 when I asked her the year, season, date, day, and month. Patient scored a 4 out of 5 when I asked her the state, county, town, clinic, and floor she was located at. She did not answer the state correctly. Patient scored a 2 out of 3 when I asked her to repeat 3 objects that I had named off, and she only got 2 correct, but that could also be due to her inadequate hearing with her old age. Patient scored a 0 out of 3 when asked to recall the 3 objects I asked her to repeat earlier. And then patient scored a 2 out of 2 when I asked her to name a pencil and a watch. Patient scored a 0 out of 1 when I asked her to repeat no ifs, ands, or buts because she used the word bus instead of butts, but this could also be due to inadequate hearing. So out of the short and mini mental that I created, the patient scored a 13 out of 24 on her mini mental state exam. Performing the rest of the neurological exam, due to her needed assistance with walking, I did not ask her to walk heel to toe. I did not assess the light touch sensation, painful sensation, or vibratory sensation due to lack of materials, nor did I assess the Babinski reflex or ankle clonus due to inconvenience of the patient. patient properly evaluated cortical and discriminatory sensation when I assessed her stereognosis, gravithesia, and proprioception. According to J.A. Wetzka and J.C. Donaldson, it would be important to perform a respiratory assessment due to the patient's diagnosis of COPD. Viral, bacterial infections, and any other respiratory abnormalities that could be missed can cause exacerbations and in turn cause morbidity, hospitalizations, and so on. According to Eric D. Peterson et al., it would be important to assess the cardiac system due to the patient's diagnosis of hypertension. Older patients with diagnosed hypertension are at an increased risk for cardiovascular and stroke events. Also, lowering blood pressure in patients with hypertension, only 10 millimeters per mercury, can result in a 25 to 40% drop in risk for cardiac and stroke events throughout a lifetime.